Well, good morning. Thank you for everyone getting here bright and early, and I am confident that this panel will not disappoint you. It will make you worth getting up for this. This is celebrating the 20th year of the original first TAVR procedure in 2002, and we've got a great diverse panel this morning. I would like them to introduce themselves, starting with my surgical colleague on the end here, Michael Reardon. Mike?
Thank you. I'm Michael Reardon. I'm a cardiac surgeon from the Houston Methodist Hospital.
I'm Megan Coylewright. I'm an interventional cardiologist from Chattanooga, Tennessee.
And I'm Artie Leon, an interventional cardiologist from Columbia University and the Cardiovascular Research Foundation.
I'm Dipti Itchhaporia. I'm president of the American College of Cardiology, and I am an interventional cardiologist.
Or play one on TV, right?
No, I don't play one on TV.
Well, I am an ex-interventional cardiologist, and well, I did the first case, so that's it.
Rox?
Hi, I'm Roxana Mehran. I'm an interventional cardiologist at Mount Sinai Hospital in New York.
So, appropriately, we're going to start with Professor Cribier. And I know you've never been asked this before, but take us through the first patient and what you were thinking at the time.
Well, actually, I was prepared to answer, what did you do before, during, and after? So I have 3 minutes, 3 questions. So
all right,
1 minute spare.
This is all about you. So what did you do before, during, and after?
Actually, one day, 1 or 2 days before, I tried to convince my partner in the United States, that doing a dying patient was a good case, was a good idea. So then I received the green light. So the second day, just 1 day before, I tried to find the right words to qualify myself, between silly, crazy, stupid, and also, well, sometimes, courageous. Well, that's it. The night before, I didn't sleep at all. I was just rehearsing what I had been doing on the last sheep, which was just before this patient. And on the day of the procedure, it was interesting. I entered into the cath lab and I saw my partner and I said, "Are you ready to go?" Hélène Chaninov, Christophe Tron. I was expecting them to say no. They said yes. So I didn't want to be the only one, ready to cancel the case. So I said yes, and we started. And it was a full improvisation because this had never been done before. Implanting a valve, not only implanting a valve, but using the transseptal approach, because we had a patient with all the contraindications that we have today for TAVI. We have to keep that in mind. He had almost no ejection fraction. He had a floating thrombus in the LV. He had no femoral arteries. He had the subacute ischemia of the leg. He was occluding 2 bypasses. And so we had to do this case transseptal. Also, he had a lot of comorbidities. So the case, step by step, I was really thinking, what should I do? Is it possible to put this 24 French introducer in the femoral vein? It looked like twice as big as a femoral vein. Then we had to push the device outside the sheath, which was a resistance there. Then doing the transseptal approach, exiting the gadwire on the other side to have a good rail, and then crossing the septum after dilating the septum with a 10mm balloon, just to cross, to go with the balloon catheter without any delivery system in the LA, and then crossing the mitral valve. At that time, when you cross the mitral valve, the pressure drops. We started with 70, we had 20 at the end of that, and then we made a U-turn in the left ventricle. It was not sure to succeed doing that. After that, we had to place the valve in the middle of the calcium and just try to do that from the femoral vein, without any delivery system. So fortunately, the guy decided to have a cardiac arrest at that time, so it was easier to position the device. We inflated, Hélène was the first person in the world to inflate a balloon catheter with a valve on it. And so the patient looked like dead. And immediately after, I removed everything very quickly, and we could see the heart starting beating again, the pressure raising to 120 millimeter of mercury. We could stop the vasopressors. And the color of the face moved from black or gray, to pink. And so it was a success. It was a success. So we had decided with Hélène, I am after the case. We were watching the clock because we had decided that if the patient did survive 30 minutes, we would say it's a success. And so I was watching the clock, and we reached 30 minutes, and the patient was smiling, moving the hands, thanking everyone for what we had been doing. And then 5 hours later, we drank the champagne with him in his room, you know. And so it was the beginning of the story. And my personal feeling was, if it had been working, it has been working this patient, you know, who is a really dying patient, the worst that you can imagine. We will have some successes with the next one. This is the way it worked.
Wow, fantastic story.
Yeah, well, 3 minutes.
So Marty, let me turn to you next. You know, you were there way back at the beginning, even before Professor Cribier, and working very closely with PVT. I see Stan Rowe here this morning. So take us through what you were thinking when you started this company, and did you really think it was going to work? And you know, what was your aha moment that you said, you know, this really is going to work?
Thanks, Mike. Well, first, it's an honor to be a colleague and a friend of Alain Cribier. He's an extraordinary individual, creative. His perseverance is unmatched. So this 20-year anniversary is exciting for all of us. So quickly, aha moments. I'm going to start with Washington, move to London, and then to New Orleans. So first aha moment was a few days before Alain's case, which he just described. Sitting in Washington on a weekend with Stan Rowe and Stan Rabinovich in Renu Vermani's pathology lab at AFIP, testing pull forces of trying to implant metal frames in human cadaveric AS aortas and annuluses. And I immediately realized that this is going to work. If we can stabilize this from a standpoint of location, this is going to be retained. And that existential moment was my first aha. Second aha, fast forward, 2010, hot summer day. I'd flown overnight with Craig Smith to the London School of Hygiene and Tropical Medicine to spend time with Stuart Pocock, and we unblinded the first very difficult and controversial partner trial. Almost 400 patients, really the worst scenario patients with AS randomized to control therapy. And we printed the first Kaplan-Meier curves and saw a 20% difference in absolute mortality. And that was shocking to me. So that was number 2. And number 3 was with Mike Reardon 3 years ago in New Orleans, presenting with Eugene Brownwald as part of the panel, the low-risk data, and demonstrating that with over 2,000 patients, 2 different platforms, well-conducted clinical trials, we were at least at a year for the given endpoints, were at least the equivalent of surgery. So those were my 3 aha moments that helped me to believe that this thing is going to work in high-risk patients, and actually could be a workhorse therapy in low-risk patients too.
So when was PVT formed, and what were you thinking at the time?
I was thinking this was, you know, a slightly crazy idea. But crazy ideas sometimes can work. I was frustrated with the state of technology for aortic stenosis. It had been a pet disease that I was very interested in. I've had wonderful experiences trying to follow Alain's path in terms of what he's been doing, and had the opportunity to work with some very creative engineers to form a startup that had an ambitious, aspirational role in trying to come up with a technology that might be a solution in the sickest patients. You know, we gave it about a, 1 in 20 chance that it could work, even for a small patient subset. Couldn't get the company financed, as FACC had to largely be self-financed to get it off the ground. We're very efficient in terms of the things we did, but it was a stepwise approach, and I have to say, you know, people think this was just a revolution that happened. It happened over 20 years, Alain, and it happened over 100 sheep in Paris, and it happened over the extraordinary efforts of engineers. And I think the clinical science played a role too. But those early days, I think our expectations were limited, and I think that the explosion that's occurred was, if not completely unexpected, was certainly for many of us was way beyond our expectations.
So, Michael, let me turn to you. You know, so many times in life you see something and you have an aha moment and you say, that's so straightforward. Why didn't I think of that? I've made no apologies to myself for not inventing TAVR. I never would have thought it could be done, because as a surgeon, I knew all the reasons why this couldn't work. When did you first hear about TAVR, and why did you immediately embrace it as a surgeon?
Well, I first heard about it because of the partner trial. I didn't really embrace it right away. I thought, well, this is going to be interesting. I'd been fooled by PCI. I didn't want to be fooled again, so I wanted to keep an open mind. I began to embrace it when we did our first couple of cases that were really very high-risk, extreme risk cases. They were all intubated. They all had TEs. They all went to an ICU. And I've learned if you want to find out how a surgeon's cases are doing, you don't ask the surgeon. You go to the ICU and you ask the nurses, how do these cases do? And I found out after about the third case, all my ICU nurses were begging to have the TAVR patients placed in their beds, not because it was an exciting new technology, but because they did so well that they required no care. And so the nurses were the ones that convinced me that these patients are doing great, and this is a technology that's going to work. If it works in these people, it's got to work in other people. These were really sick people, as you remember, that we started with.
So Dipti, talk to me about the ACC and the role that they had in TAVR over the last 20 years. You know, the college embraced it early on. They partnered with the STS Surgical Society and a lot of education programs. So kind of take me through the college's role in the rollout and development of TAVR.
You know, somebody said the other day that there's the right president at the right time for the college, and at that time it was David Holmes, and then you were there. And so I think that you guys helped shepherd the TVT registry, for example. That has been a really important piece of getting the information and the data that we need to inform us where we go forward. The college really embraced the technology, certainly at having presentations at meetings like this, but also doing a great job of educating through our curriculum that we develop for educating clinicians about what is the data, how do they utilize it, and where do we go forward with that?
Great. So Roxana, let me turn to you. You've had a front row seat on this from way back at the beginning, and you wear many hats, but one of them is as a trialist. So can you take us through what your thoughts are about the evidence base that's rolled out for this, and please talk about the gender aspect of this.
Yeah, first of all, this is, I believe, the most incredible model for how we should be gathering evidence. Every single clinical trial in TAVR has been prospective, well-controlled, randomized, powered for the endpoints in the patients that needed it most, against the best possible therapy available to them. Incredible. The number of New England Journal articles speaks for the fantastic work that's been done by the investigators that brought this forth. So to me, this particular technology now becomes, and I always say, complemented by the TVT registry for all. We now have data in randomized controlled trials, in real-world patient populations for long periods of time, not just in a 1 year, but going out to 5 years. Today we're going to hear 5-year data from Sir Tavi. There is a tremendous body of evidence that's being built here. So I can't imagine any other technology that has put more effort into this kind of work with large randomized clinical trials. So I think you all need to be congratulated for the work that you have done. And that is why TAVR now is TAVR first. And it's how we are looking at it. Patients want it because the evidence is so strong. And by the way, I think when you study a disease state that is affected by women, you're going to get more female patient population. But also, I think we need to continue to work to not only have, there's 50% female patients in our TAVR populations and in the clinical trials, and we're able to do the sex-based analyses, and every single one of these trials have presented the sex analyses, which you then again need to be congratulated for because other trials don't do it. And it's, again, another fantastic example. And now we're exploring more about possibility of maybe small annulus, looking for what might be better for women, which valve, and that's being examined. So I just can't say any bad thing, and I usually have something bad to say. So it's been a fantastic ride, and congratulations to all of the leaders, and especially to the principal investigators, to the companies that have stood behind the technology to make sure that we move ahead with the best possible evidence forward.
Great. So, Megan, let me turn to you. So, one of the collateral benefits of TAVR has been the formation of the heart team. And I first met you a number of years ago when you were at Mayo Clinic with one of your mentors, David Holmes, and you wrote about the heart team early on. Can you kind of talk about that as TAVR rolled out here, and you know how it's evolved today, and is it an effective model, and what could be done to make it better?
I will say, when you have leadership like those around me, you can't even imagine the impact you have on the world. So when you were all doing your early cases, I was in Baltimore as a medical student, rounding with Eduardo Marban, and I heard this rumor in 2003 that someone had put a valve in through someone's leg. And that changed the entire course of my career. This is the most amazing thing I've ever heard of, and I need to be a part of it. And when I was at Mayo Clinic training under David Holmes and Rakesh Suri, the cardiac surgeon that helped train me, I really felt like, for whom much is given, much is expected. And I thought, what is my role in this journey? And my own expertise is in healthcare delivery and patient engagement. And so David and I started talking about, everyone is so excited about the heart team. It seems like the perfect model, bringing an interventional cardiologist and a cardiac surgeon together to make decisions when before they'd been so siloed. And on every stage where we've seen someone give a talk, everybody champions the heart team. And it has been a big improvement. But we've never innovated it, and we've never tested it to see how it can be most effective. And it is an intervention. It changed the way we deliver care. And there are great things about it, and there are challenging things about it. We hope that in every heart team there's a collaborative discussion, but sometimes there's groupthink. There's a dominant voice that decides the care in that hospital, the way care will go. Sometimes people are not included in those discussions, especially the patient voice. The further we've gotten from making decisions in the clinic, the further we've gotten from our patients. We're now in a conference room on a different day at a different time, and sometimes we'll have just a nurse call back to the patient and tell them what the decision is. So I think the future of the heart team is patient engagement. And Marty and I have struggled in the Heart Valve Collaboratory trying to think about what is the methodology in which we study this. And so I think that's the years ahead of us.
Great. So, Marty, there's 3 pillars of clinical adoption of any new technology. And one is user or operator friendliness. The second is education of clinicians and operators. And the third is generation of a robust evidence base, as you've heard from Roxana here. And obviously all 3 played a role here, but could you kind of give your thoughts as to which one, if any of those, was the most predominant factor that drove robust clinical adoption over the last 20 years?
It's a great question, Mike. I think all are important. I think you need the clinical evidence. I think that you need great technology. You need a team of people who are committed, but also who are somewhat self-critical. I think that helped us. But for me, what really has distinguished this is, and it takes off a little bit on what Mike was saying, which is the simplicity of the technology, the ability to generalize it to a large population of operators and sites. There are over 790 sites, part of the TVT registry. We trained sites for the first 5 years, almost twice a month. It was a process, but once trained, I think to be able to generalize it and the simplicity of the application, the ability to adopt what people call this minimalist strategy has made a remarkable difference in terms of people really embracing this within the larger healthcare community.
So Dipti, let me ask you. So we do have the TVT registry, and I think it's clearly documented in virtually every patient in the United States that's received one that the real-world results are the same as the randomized trials. What are your thoughts there? I mean, is that true, and did the TVT registry help increase adoption here?
Oh, absolutely. I think that, you know, the idea that, I mean, how many times have we heard that, oh, that patient doesn't fit my patient, that mine is a little bit different. So I think to know how the real world actually does when you're not having certain, you know, exclusion criteria or inclusion criteria, and just using those patients and seeing how that translates into daily practice has been extremely informative. And I think that's made a big difference.
So Alain, let me turn back to you here. You know, so many times in life we do, pardon my French, use the woulda, coulda, shoulda. That means, what would have I have done differently? What could I have done differently? Or what should I have done differently? What are your do-overs here? Would you have done anything differently? And you have more than 3 minutes to answer this question.
Yes, well, actually, thank you. Thank you. I have a question to your questions. You know, why are you asking this question to me? You know, because, well, you know, you never have to change something which is working. And it has been working all the time since the very beginning. So when I think back to what has been done, I don't see anything that I could change, you know, to improve again or to accelerate the expansion of this technology, which has been absolutely fabulous. And so my answer to your question definitely is no. I don't see anything that I could have changed, you know, to make it easier, faster, or whatsoever. You know, I just followed the run. So that's all. I just would like to say just a little things about the registry and evidence-based. You know, of course, I trust very much evidence-based data, but and it was amazing that when we did the first Partner 1 trial, you know, the surgeons were very experienced, and the interventional cardiologist has zero experience of this technology. And at the end of the game, you know, the results were similar. So I think that this evidence-based data for the first trial on high-risk patients was extraordinarily important. Also, I trust very much the control registry that you have in the United States, you know, because this gives a very true idea of exactly where we are. And in France, we have the France 2 registry, which is also one of the biggest registry that is existing, and showing exactly what we can expect of this technology, how much it can improve the patient, and what kind of complication we have on a regular basis on with people who have been trained to do this technology. So it's give a very, very accurate image of the situation in France and in the world of this technology. So I trust very much this big registry, like the American registry, of course. Yeah.
So let me ask you this. As you alluded to, the first patient you did this on was incredibly sick. And we know that when other technologies have come out, the first patients haven't been successful. John Gibbon with the first heart-lung machine, the first 4 patients died. Morrow with septal myectomy, 4 of the first 5 patients died. What if this first patient hadn't survived? What would you have done?
Cry and put my excuses to my partner. You know, I should have said, I pushed you to accept this case, which was absolutely stupid and crazy again, so I should not have done that. But I will immediately move to the next patient, you know, and but the problem with the startup, you know, is that we have a limitation in the finances and the techniques and technology, and you know, so we cannot do what a first failure has a big consequences for a startup company, I can tell you, and I would have feel very, very bad. Yeah.
So, so I heard Roxana interview you the other day. Share with us what you did after this first procedure was successful.
On the patient or?
No, yourself.
Yourself, what I did? Well, I went to my car and cried. Yeah, so this is something that I can tell. I had to unload the stress, you know, because it was so stressful. And I didn't sleep the whole night. You know, people were crying in the cath lab. You know, so the nurses were crying. We were all embracing each other, and it was even the patient was crying. You know, so it was unbelievable. So I did that, and after that I spent, I would say, 1 hour with my partner in the United States, with Stan Moe and Martin Leon and so on, to explain exactly well what we had been doing. And having their feedback was extraordinarily exciting to me, you know, because, and after that I was thinking of the future, and the future was to be allowed to start around first series of patients. And I had to struggle, I can tell you, during 1 year with the health authority in France to get this approved for a series of patients on compassionate basis, 15 days of life expectancy, and transeptal approach only. You know, so it was, you know, it was something great.
So, Marty, Alain called you about this first patient, correct?
Yes, actually, we exchanged multiple emails before the case, which someday maybe we'll share. And look, it was an extraordinary case. He had no options. This is a man in his 50s with an LVEF of 10%, with a mobile LV thrombus, no arterial access. I mean, this was who had been in cardiogenic shock and had failed valvuloplasty multiple times, and was not a surgical candidate. So I mean, you hate to have to be forced into doing a new procedure like this. And Alain did two things special. He implanted the first valve, and he proved that if you do TAVI, it's a treatment for ventricular fibrillation.
So, Marty, let me ask you another question here. So, the transeptal approach turned out to be extremely prohibitive in terms of being able to repeatedly do this. Can you talk about how other access approaches evolved after Alain's initial antegrade transeptal approach? Absolutely.
Here's where I invoke some of the choice words of my friend David Holmes. The transeptal procedures were rich emotional experiences. Our first two cases at Columbia died. They were extreme risk patients. And we really wondered if this is an approach that could be generalizable, and quickly, through some of the insight, frankly, and the courage of our sponsor colleagues, and I won't mention who all of them are, we agreed to stop and to rethink how we would go about doing this. At the same time, people like John Webb were, moving ahead quickly with a retrograde transarterial approach. There was additional work that was being done by colleagues with self-expanding devices from the arterial side. So I think we began quickly to realize that this was going to be the technique of the future. So we took a hiatus to redevelop the technology to be able to go retrograde aortic, and that made all the difference.
So, Michael, let me turn back to you. So there was an extensive effort early on to train surgeons in TAVR, and you, among others, were the loudest voices shouting from the rooftops, this is going to change the world. And although some surgeons embraced it, and there's some very skillful cardiac surgeons, mainly which Marty trained, like Matt Williams and Isaac George, only a minority of surgeons really have embraced it. Kind of give your thoughts as to, wind the clock back to that time, and what could we have done differently as surgeons?
Well, I think it's important for us to realize that this is not for every surgeon. There's going to be a subset of surgeons that are going to do this, and they need to understand that it's not implanting the valve that makes you a TAVR surgeon. It's understanding the whole procedure and the patient selection and the device selection and the aftercare that makes you a TAVR surgeon. And so at my place, I have two younger faculty that do this, and I encourage them to do TAVR 1 day a week each, and then surgery the rest of the days, because they're still surgeons. My interventionists would be happy to do this every day of the week, but that's different. I would like to go off script a little bit, though, and say that, surgeons, and this as a surgeon, have always worried about interventional things that's going to take down surgery. I think this has actually made surgery so much better than we would have been. We used to look at valve duration as a normal valve or a bad valve. We're now looking at it, because of TAVR, as a spectrum of valves. And I think that this has made surgeons think about what they do. Marty knows when we got to the low-risk trial, surgeons have been competing against TAVR, and they're learning to put in bigger valves and get better EOAs. TAVR has forced surgeons to be better surgeons. So not only has this been good for our patients, but I have to say this has really been good for the field of surgery. It's forced us to rethink how we do things.
So we've got about 15 minutes left here, and let's turn a little bit to the future here. And Roxana, tell me, where does TAVR go from here? What are the current evidence gaps, and what studies do we need to do going forward, and how do you see it evolving from here?
Yeah, I think one of the most important questions is how do we treat patients in their lifetime for aortic stenosis? And so we're going to need to figure that out as clinicians, as trialists, as investigators. We need to, and I think that the TVT registry could help us tremendously in understanding the procedure after procedure and how we make those choices. I think the gaps are making sure that this technology is available to all humans of all races and socioeconomic status, and I think that's a big effort that's ongoing in terms of making sure that we're inclusive and that we have inclusion of African Americans as well as Hispanics, Latinas, et cetera, in the United States that receive this important device. And importantly, and lastly, I want to say that everything has been done so beautifully in this particular field in terms of gathering evidence. And so we need this to be a durable, effective therapy for a very long time in the lifetime of a patient with aortic stenosis. And how we do this is as team effort with our surgical colleagues. Also, we need to understand the pharmacology that goes along with it so that we can make sure that the durability of that valve is tremendous for the patient and that we could get the most effective use of this technology in the lifetime of a patient. And how we do this is going to be very creative and interesting and out-of-the-box thinking in terms of how we design the next trials. And I think we're doing that, and you're all doing that, thinking about these things going forward.
So Marty, let me turn to you then. What are the next trials? What are the evidence gaps, and what trials are being done in order to help answer them and to move the whole field forward?
Yeah, I think it's really important that we not stand still. We're still treating the vast minority of symptomatic severe AS patients. And it's based upon a trigger point and guidelines that really say that we treat patients only at a certain point in the life spectrum of their disease. So we've thought that we need to break those barriers, and we need to talk about different ways of approaching patients. First, access to diagnosis, access to care. Rox has mentioned that. But upstream, preemptive TAVR, we think is a very viable treatment in patients who are less or asymptomatic if they have at-risk features. So there are ongoing trials and future trials that will be done. There's the early TAVR trial in severe asymptomatic AS. There are 2 trials that are in moderate AS with certain at-risk features. So I do believe that those are going to be important trials to open up new patient populations that potentially could be treated. When you have a technology that's less invasive, that has very, very low risk, then I think you could begin to explore those kinds of studies. I would also say, and as an interventionalist, it's hard for me to say this, that the pharmacologic treatment of calcific aortic valve disease has been neglected, and I think there are many creative new pharmacologic approaches that could delay the progression of aortic stenosis. So that's an area that I think really needs to be explored over the next 10 years, going beyond the previous statin phase of clinical trials for AS. And finally, I think going forward beyond the procedure, downstream, we have to improve the durability of bioprosthetic valves. So a lot of effort's got to go into trying to modify, and this is going to be technology in terms of valve leaflet technology, new systems that are going to take us beyond what the current limits are of bioprosthetic valves so that we can, at some point, treat much younger patients, and we can talk about a one valve for life as opposed to this concept of multiple sequencing procedures in younger patients.
So Megan, you mentioned that TAVI changed your life and your career. And you've become very, very passionate about it ever since you first heard about it, but you're even more passionate about shared decision-making in the heart team. How do we do that better? Logistically, it's been hard for centers to do. There is no one-size-fits-all. So how do we do that, and how do we generate the evidence that this really is a better way to do things?
Well, listening to Roxana and Marty talk about what's to come with regards to trials, I think we can all hear patient choice and patient preferences are going to be embedded even more in the future than they have been in the past. When we think about the 2 large randomized clinical trials in moderate aortic stenosis for patients that have some evidence of heart damage, this is a tough choice for patients. We're just all approaching them now to talk to them about it. You know, when we have preference-sensitive decisions, where people who have different backgrounds, their age, their race, class, gender, makes them weigh them differently, those are the decisions where shared decision-making is appropriate. And I would say that's the majority of decisions in aortic stenosis. There are still some that are not preference-sensitive. Someone with a long life expectancy who has terrible LVOT calcium is not a TAVR technical candidate. There's not a choice to be made there. There's one answer that the weight of the evidence favors, or a 90-year-old with beautiful transfemoral arterial access. The weight of the evidence favors one option over the other. But for a lot of our patients, there are reasonable options on both sides. So you're asking about implementation of shared decision-making, and it has been difficult across our healthcare sites, but I think it is improving, in part because some of it has been our culture in cardiology and cardiac surgery, that we feel like we do that every time we meet with a patient. We're always talking to patients. But really listening and eliciting patient preferences is challenging. So the ACC has been a leader in that through our patient engagement program called CardioSmart, where decision aids live, and where you can access them for your patients. But I think it will continue to be testing those healthcare delivery interventions and making sure that along the course of all of this exciting technology and trials that our patients are walking along with us in that.
So, Dipti, truly the last 20 years have been transformational. Can you kind of share some of the lessons that have been learned about the way that TAVR has rolled out, what the college has learned, and is this lightning strikes once and never again? Are there lessons learned that are applicable to the next therapy and the next therapy and the next therapy that come out?
No, there are many lessons. You know, Arthur Roy Bennett said, don't be pushed around by the fears in your mind, but be led by the dreams in your heart. And I think that really, besides underscoring the importance of the cardiovascular care team, and think about that, we learned how to collaborate, not only with cardiologists, with, you know, our cardiac surgeons, but also physicians with industry. And I think there's a lot of lessons around how to collaborate and how to do that. We learned how to rapidly, do iterations of our devices. Look at the way that there's spillover now for other valves. So what we learned about valvular heart disease just in general. Think about frailty. Did we think about the frailty of a patient before quite the way that we do now? So there are many lessons, but I also think that one of the big lessons is this notion, and Alain, you said this during my interview with you, which is this notion of not giving up. You said that, you answered the question earlier, what would have happened if the patient had died? And you said, I would have gotten up and done another patient. So this idea I want to really underscore is to not give up, right? And I think that the college's hope is that we can use the story of TAVR and help write new stories, right? Because it is inspirational to hear individuals that have done this journey and what are the opportunities to really transform cardiovascular care going forward. I mean, what's our mission statement? Transform cardiovascular care and improve heart health. We're not going to do that unless we're bold and courageous to go forward. And you know, I've talked a lot during my presidential year about the importance of recognizing and leveraging disruptive innovation. Can you think of a better disruptive innovation than this to optimize care and to transform care? So I think that we need to continue to nurture this notion of disruptive innovation, not go away from it. I think that we need to find the courage, the inspiration with stories like this. This is why I think this has been such a great idea. And I think that we need to think about how to do things better. it's been interesting to hear Marty and and Roxana talk about what the future is. And we've already seen some of these innovations, right? Look at the way clinical trials we're thinking about how to do clinical trials differently. Beyond randomization, which is expensive, slow, and outdated, we're thinking about process innovation for patient safety to make an experience. We're talking about how to make the devices better. What can we do going forward? So I think there's a lot of lessons here.
Great. So I want to give the panel a heads up here. We're going to spend the last 5 minutes. I'm going to ask each of you for your final thoughts. And so if you want to take a minute to kind of compose a profound thought to leave us with at the end. But before I do that, Marty, Professor Cribier called this TAVI, and the Americans all call it TAVR. Why is that?
Well, frankly, I'm not sure that it's an important difference. We started calling this a TAVI in the early days because it truly is an implantation of a valve. When we tried to, and in fact, the first partner paper was called TAVI. Then we realized from a reimbursement standpoint that unless we called it a valve replacement, it would potentially threaten some of the reimbursement issues. That shifted us to thinking that this is a functional replacement of the valve. It's not just an implantation. And when you put in a mitral valve, you leave the existing valve in, and you don't call it mitral valve implantation. So we went back to what we thought was a more true and correct description of the procedure, which is a functional replacement of the aortic valve. So we've retained largely the TAVR acronym, although to me, TAVR, TAVI, it's all the same thing.
Alain, what do you still call it?
Well, actually, there is no doubt for me, because TAVI in French means your life, so it's very beautiful. And this is why we accepted this word, immediately, your life. Well, if I can say a very short thing to conclude, I am very, I would say, satisfied by the way things have been working since the very first case. I think it was a good idea. And I have been absolutely amazed by the way the technique has been expanding and so on. But this is on a technical point of view, things are going to be easier with many iterations of the device. But we are getting down to 1% death and 1% stroke at 1 year and this kind of thing with the next generation device. That's great. This is technique. But I think TAVI really brought many other things beyond the fact of improving the technology and changing the aortic valve. It has changed the philosophy. We consider the patient. And as it was said at the beginning, personally, I have always tried to put the patient at the center of the heart team decision. The patient is the one who takes the final decision, actually. And so he has to be absolutely informed of everything, the risks, the advantages, etc. And the patient is the heart of the problem. So I think we have considered this part of medicine very differently. And Roxana said, now TAVR will work on how to create a valve that would have a very long-term durability. This is the goal. I wonder why the surgeon didn't had that in mind, before, because it was exactly the same problem. And so, the TAVR has brought a new concept, a new philosophy of how to do medicine and work in a partnership and so on. And I am glad of that. Yeah. Thank you.
Fantastic. Roxana, final thoughts.
So I'll conclude that TAVR has been the most collaborative experience in the history of medicine. If you think about how it's brought all of us together, including our patients at the center, making us better clinicians, better surgeons, better cardiologists, and absolutely better caretakers with all of our passion. And by the way, it has brought us a very close collaboration with our sponsors and this private-public partnership, making it absolutely a very strong bond to improve and enhance human health. This is what TAVR has done. Congratulations. Happy birthday.
Dipti, how do you follow that?
That one's a really hard one to follow, but I think that I'm going to take the tack of, one of the things I've talked about this whole year is digital transformation, innovation, and all of that. And I think that to see this technology, to be able to celebrate 20 years of TAVR, is only sort of hearkening all of those inventors and entrepreneurs out there to say that things are possible.
Marty?
Yeah, these are all very profound statements. So when we presented the low-risk data in New Orleans together, my son was there, and he's not of a medical mind, but he's of a technical mind. And the only thing he could say was, "Dad, I didn't know that TAVR was so awesome." And that really is the word that really describes it. It's awesome in every respect in terms of being the right technology that really leverages less invasive techniques for a sick population, taught interventionalists to stop having ADHD and just focus on the first 6 months after a procedure, but to treat patients with cardiovascular disease during their life history, and to understand that you have to be more involved before and after. It's taught us that image-guided therapy now is something that's come natural to us, was unheard of 20 years ago. It's brought in a heart team to be able to manage cardiovascular disease in ways that were never done before. So in every respect, I think that TAVR or TAVI has been truly awesome.
Megan?
At this meeting, I was able to pull together my team of about 40 assistant editors that are all committed to developing patient decision aids and shared decision-making tools. And a lot of them are from our cardiovascular care team, APPs and nurses. And so I do think this is an important part of our journey. And one of them, Viet Lee, who's a PA, said, "You know, the patient is the pilot, and we are just their navigator." And I just want to thank Elaine for drawing the map. So now I can just ask them where they want to go.
Michael, surgeon, final word here.
Well, a blatant plug. If you come to my late breaker next door right after this, I've gone back to TAVI, but it's just me trying to appear more French. So,
So I'm going to take the chair's prerogative here at the end, and I think that everybody here on stage and everybody in the audience needs to give Professor Cribier a standing ovation on the opportunity here.